Hello, good morning, everyone.
Good morning, sir.
Am I audible? So, shall we start?
Yes, sir.
Okay. Okay, today we will be discussing about the fetal lie, fetal attitude, presentation, and position. Okay, so this is very important more practically. Okay, so while doing routine obstetric examination, we try to find what is the fetal lie, what is presentation, and what is position. It's bit difficult to identify the attitude, but also we can do from the examination. Okay, so today we'll talk about same. So it's more practical topic. So you will be uh, discuss this. We will discuss this topic in our tutorial as well. Okay. So today's objective. So we'll talk about fetal lie, presentation, attitude, and position, and how we diagnose fetal presentation position by clinical method, by physical and radiological method. Okay. So let's start with the fetal lie. Fetal lie. It is a Yes, lie is in relation to the long axis of the fetus to the long axis of maternal spine or centralized uterus. Okay, so remember it is a relation of the long axis of the fetus. Okay, if this is a fetus and the long axis of the uterus, so it should be lie should when you say it should be parallel. Okay, so if it's a longitudinal lie, okay, it will be transverse if it's a or it will be 90-degree if it's a transverse lie, or it's oblique. Okay, so lie is basically a relation of the long axis of the fetus. Okay, when you take the long axis of the fetus, taking the spine, fetal spine, to that of the long axis of the maternal spine. Okay, so two spine you can compare, or centralized uterus. Okay, so either maternal spine or centralized uterus. You better to use centralized uterus, because sometimes the uterus may be deviated, and the centralized uterus, the uterine axis as well as fetal axis, they lie parallelly. Okay, they lie the long axis lie remains same, then in that case that is also longitudinal lie. Okay, so I will show you in figure. And other transverse or oblique. So let's say in the picture, so both these figure A and figure 2 both are longitudinal lie. So when you compare with the maternal spine, here is a it looks like it's an oblique lie, but here the uterus is deviated. Okay, so that's why So that's why always we have to centralize the uterus before examining. Okay, that's why when we do Leopold maneuver, okay, when we do clinical examination, we have to centralize the uterus, because this is the reason, because we may have false impression. Okay, so this may be oblique lie. Okay, no, but this is a longitudinal lie, because when you compare the centralized uterus with the fetal axis, then they are same. Okay, they are parallel. Okay, so this is longitudinal lie. Oblique lie. Now the uterus is, and now you can compare with the maternal spine as well. Okay, so here the angle is almost 45-degree. Okay, so this is the oblique lie. So in this case, it is 90-degree. Okay, so this is transverse lie. Okay, so lie is basically the centralized uterus and the axis of uterus. Fetal spine or maternal spine. Okay, so in this case, this is both. These are longitudinal lie. Okay, so you can see fetal spine, and here will be the uterus. Okay, so this is the longitudinal lie, and same. Okay, in both case, lie is longitudinal. So this is transverse lie. So if this is the uterus, then the fetal lies across. Okay, so the angle is 90-degree. Okay, that's why this is the transverse lie. Okay, so what are the predisposing factor for the abnormal lie? So we know longitudinal lie, it accounts for almost 99.9 or 99.5%. Okay, so because that is the normal lie, and all other lie, oblique lie, transverse lie, these are abnormal lie, because the labor is not possible in such cases. Okay, so what are the predisposing factor for abnormal lie apart from longitudinal lie? Okay, what are the factors? Multiparity. When the patient become more pregnant, okay, so pregnant for multiple times, then the uterus the elasticity of the uterus will be less, the tone will be less. That's why, because of the inelastic tone of the uterus, the lie will be flexible, it will change. Okay, so usually that's why multiparous, the uterine tone is weak than that of the primary. Okay, first time pregnant. Or the placenta previa, when the placenta lies occupies the lower uterine segment, so in that case the lie will be abnormal in majority of the cases. Okay, similarly polyhydramnios, when there is a Leica axis, the usually baby floats. Okay, so lie will be abnormal and uterine anomaly. So now let's discuss about the presentation. So what is presentation? Presentation is a part of the fetus which occupies the lower pole of the uterus. Okay, so lie, we just look at the longitudinal axis of the fetus as well as that of the gravid uterus. Okay, but in case of presentation, what occupies the lower segment? Okay, so is it a, okay, so let's say in this case, so here in the lower segment the fetal head is applied. Okay, that we call cephalic. Okay, so in this case, if we compare this, so in this case the buttock is the presenting part. Okay, and when the baby lies transversely, in that case it could be shoulder. Okay, so this is the part of the fetus which occupies the lower pole of the uterus. Okay, or the pelvic rim. So different types. So most common is a normal or normal presentation. What we call normal presentation is cephalic. Okay, another is podalic. So podalic means bridge. Okay, when the buttock lies, we call it podalic or bridge, and it lies around 3 to 4% of the cases. Okay, and the shoulder presentation. Shoulder presentation, if the lie is usually a transverse lie, in that case the presenting part, okay, the presentation, the part which occupies the lower segment, okay, that is shoulder. Okay, so what about when more than one part of the fetus is present? So in that case we call it compound presentation. Okay, so let's say sometimes the fetal head and the hand is there, we call it compound presentation. Okay, so let's see. So in previous figure we discussed about, we just talk about the lie. Okay, so both these are longitudinal lie, but here the presentation is different. Why? Because what occupies the lower pole? Look at the lower pole of the fetus. Lower pole, pelvic rim, which occupies the pelvic rim or lower pole of the uterus. Here it is head, so it's cephalic presentation. Here it's the buttock, that's why we call it bridge. Okay, or podalic presentation. Okay, what is compound presentation? When more than one part occupies in the lower segment, here the head as well as hand. Okay, so that's why we call it compound presentation. Okay, now another topic, what is presenting part? Okay, so presenting part means the part of the presentation. Okay, so now we are going more and more detail. So first we talk about lie, just we compare the longitudinal axis of the mother and fetus. In presentation, what occupies the lower pole of the uterus? Now presenting part, you go more detail about the presentation. Okay, the part of the presentation which overlies the internal os. Okay, especially when we do part vaginal examination, PV examination, we try to find this part. Okay, so the presenting part is the presentation which overlies the internal os. Okay, and it is felt by the examining finger during the cervical opening, during PV examination. Okay, sometimes we use synonymously presentation and the presenting part. Okay, so let's discuss about presenting part. So presenting part, we go more detail about the presentation. So in cephalic presentation, there could be different presenting part. Okay, that means which overlies the internal os. So you can see, so this is the quadrangular area of the fetal head, which is called vertex. Okay, so if the fetal head is well flexed, okay, well flexed, this is the most common presenting part, that is vertex. Okay, what is brow? So you can see here, head is deflexed. Okay, it is partially extended, and the frontum, okay, the frontal part usually is presented over the internal os. Okay, this is brow. Excuse me. And look, when it's fully extended, okay, when the fetal head is fully extended, the face present over the internal os. Okay, so it depends upon the degree of flexion, and just deflex, it is still a deflex vertex. Okay, so attitude, we'll discuss again about the attitude. So attitude is a relation of the fetus to one another. Okay, so you can see in these thing, the lie is longitudinal, presentation is cephalic in everyone. Okay, so what is the difference here? It's the attitude, because the here is completely flexion, it's deflex. Here it's a brow, it is partially extended, and it is fully extended. Okay, so according to the different attitude, the presenting part will be different. Okay, so here the presenting part will be vertex, in this case again vertex, here brow, this is the face. Okay, so remember, if it's a face, then you try to feel the part of the face. Okay, and if it's a frontum, brow presentation, you try to locate the sinciput. Okay, which is over the frontal bone. Okay, we call brow, this forehead we call sinciput. Okay, so anterior to the anterior fontanelle, okay, just above the glabella, we call it sinciput. Okay, what is vortex? Vortex is a quadrangular area. Okay, which includes, here it's a posterior fontanelle, anterior fontanelle. Okay, here it is a temporal bone. Okay, and here is the occiput. Okay, so it includes the quadrangular area. Okay, okay, so let's discuss a face as a presenting part. So though it is a part, here the presentation is cephalic and presenting part is the face. We usually call a face presentation. Okay, ideally, okay, by definition, it should be face as a presenting part, but commonly we use the term face presentation. Okay, so here the fetal leg is sharply extended. Okay, fully extended, so that the occiput and the back come in contact, and the face is the foremost in the birth canal. Okay, so you can see the face is the foremost in the birth canal. Okay, that's why we find the facial structure when do PV examination. Okay, so this is the face as a presenting part, or simply face presentation. Okay, brow as a presenting part. So in brow, it is the rarest variety. Okay, of the cephalic presentation, where the presenting part is brow, that is sinciput. Okay, and the fetal attitude is short depth, degree of extension necessary to produce the face presentation. Okay, it's not fully, that means it's not fully extended. Okay, it's just a partial extension. Okay, so in fact it is between the full flexion and extension. Okay, so it lies in a position where there is full flexion as well as between the full flexion and extension. Here the denominator is frontum. Okay, now we'll talk about the denominator. Again, we are going more and more detail in the presenting part. Okay, so this is a fixed part in the presenting part, which lies in relation to medulla pelvis. Okay, so another presenting part. Okay, in case of bridge, podalic, what can be the presenting part? What are the different bridge types of bridge? Okay, so it depends. Okay, so though all are bridge, you can see here the leg is extended. Okay, so the leg are extended at the hip joint, fully flexed at the hip joint and extended at the knee joint. So what we call this type of the bridge, it is the extended bridge. Okay, another is, you can see here the flexion, both at both joint. Okay, hip joint as well as knee joint, the legs are flexed. This we call flex bridge. Okay, and a foot may present. Okay, sometimes the foot may present, foot as a presenting part. So this type of this type of the bridge we call foot-link bridge. Okay, so it depends. So it depends upon how the fetal lie, even if it's a bridge presentation or cephalic presentation. Okay, so we have to determine the presenting part. What about the fetal attitude? Okay, so attitude means it's relation of the different part of the fetus to one another. Okay, it can be flexion, it can be extension. Okay, it's just a relation of the, there is no relation with the medulla pelvis. Okay, here it is, we just look at the fetus only, how the fetus is lying. Is it flexed? Is it where it is extended? Okay, it's just a relation of the different part of the fetus to the one another. Okay, the universal attitude is flexion. In case of cephalic presentation, it is flexion. Okay, and all other attitude includes fetal extension. Okay, head extension. It can be deflex or brow or face. In such cases, usually the attitude is extension. Okay, according to the degree of extension. If it's fully extended, then it's face, partially, then it's brow, deflex just partially, then it is sinciput presentation. Sorry, this is the deflex vertex. Okay, or in case of bridge, we can look at the leg. Leg can be extended, flex. Okay, so these are the fetal attitude. It is a relation of the different part of the fetus to one another. So now let's see in the picture. So you can see the different attitude of the fetus. Okay, lies longitudinal, cephalic presentation. Okay, same, but look at the presenting part which overlies the internal os. Okay, so here is the vertex, still vertex. Here it is the frontum. Here is the face. Okay, so it depends. That's why the presenting part is also changes because of the fetal attitude. Okay, so you can see the changes in the attitude in relation to the vertex as the fetal head becomes less flexed. Okay, when become less flexed, now it changes from the vertex to brow, okay, to face. So attitude has a role in presenting part. Okay, another important one is denominator. Okay, this is very, very important. Okay, because this is the point. Okay, this is the arbitrary bony fixed point on the presenting part. Now again, we are going in more detail in the presenting part. Okay, we try to look at the fixed point even in the presenting part, because it is a huge, it is a big area. Okay, the presenting part is a big area, so that's why we try to look at a fixed point. Okay, which comes in relation to various quadrant of the maternal pelvis. Okay, so this is what we call denominator. It is arbitrary bony fixed point on the presenting part. Okay, which comes in relation with the various quadrant of the maternal pelvis. So in case of vertex, it is a quadrangular area. Okay, so big area, quadrangular area. But what is the denominator in case of vertex? It is the occiput. Okay, so it's the occiput. Okay, we try to look in case of, we try to feel in case of vertex presentation. This is the denominator. Okay, what about in the face presentation? Yes, it is the mentum. Okay, and frontal eminence in case of brow. Okay, sacrum in case of bridge. Okay, acromion in case of soldier. Okay, these are the bony fixed point. Okay, on the presenting part, which comes in relation to the various maternal quadrants. This is called denominator. Okay, this is very, very important. Now, what is the position? Basically, it is a relation of the denominator to the different quadrant of position. Okay, so where the denominator is lying now, your aim is to locate the denominator first and compare. Okay, is it in anterior position or posterior position or in a transverse position? Okay, so any position. So maternal pelvis, theoretically, we can divide into up to 8 position. Okay, so it can be anterior, okay, posterior position, transverse position, or in between. Okay, that's why theoretically there are 8 positions. So we'll do bit exercise, then it will be easy. Okay, to remember. So you should know bit about the fetal skull. So this is will be dealt in detail in another lecture as well. Okay, just let's know the few part. Okay, so this is the fetal skull, and this is the anterior fontanelle. Okay, this is the anterior fontanelle. Anterior fontanelle is made by, so here anteriorly it lies the sagittal suture. Okay, basically these are the gap in the bone. Okay, transversely is a lambdoidal suture. Okay, this is this sorry, this is a coronal suture, not lambdoidal suture. This is a coronal suture, and anterior vertically it is a sagittal suture. Okay, this is the frontal suture. So this is the quadrangular diamond shaped fontanelle, but posterior it is transversely lambdoidal suture. Anteriorly it lies a posterior fontanelle. Sorry, anterior lies sagittal suture. Okay, in between this is space, triangular area is called posterior fontanelle. Okay, so in case of vertex, the vertex is whole. Okay, it is the quadrangular area, but what is the denominator? What is the bony fixed point in relation to the pelvis? In case of vertex, it is the occiput. Okay, In case of frontum, it is a sinciput. Okay, so this is the bony fixed point. So now let's discuss about the position. Okay, so position, it comes, what is, for position, you should first determine what is the denominator. Okay, once you know the denominator, okay, then it will be easy. Okay, in case of cephalic presentation, presenting part is usually a vertex. Okay, that is the most common, and that is normal presenting part. Okay, then what is the denominator in case of vertex? Yes, it is the occiput. Okay, now you look at the occiput. Okay, so how to find the occiput? Look at the fontanelle. Okay, so this is the anterior fontanelle, this is the posterior fontanelle. Okay, so in relation to the posterior fontanelle, this is the occiput. Now you can see the occiput is anteriorly or posterior. So sorry, this is the posterior part. Okay, remember, this is the posterior part and this is the anterior part. Okay, so this is symphysis pubis. Now look, here is the occiput. So occiput is anterior. Okay, this is we call occipital anterior position. Now here also anterior, but it's in the left side. So we call it left occipital anterior. Here in the right, okay, occiput, that is right occipital anterior. Now the occiput lies on the transversely. Okay, so this is occipital transverse. Occiput lies on the left and it's in the transverse. Okay, left occipital transverse. Here the right occipital transverse. Similarly, look at the occiput, it lies posteriorly. So this part is the posterior. Here is the metal spine. Okay, this is right occipital posterior and left occipital posterior, and this is occipital posterior position, direct occipital posterior position. Okay, so there are theoretical total 8 position. So position, it is easy once you locate denominator. Okay, so you can see here, try to locate what is the presenting part. So you can feel you can see the skull. So here the lie is longitudinal lie, cephalic presentation, presenting part as a vertex. Now go in detail about the presenting part. What is the denominator? So denominator is here occiput. There is a bony fixed point. Okay, so occiput. Now look at the position of the occiput. So it lies anteriorly. Yes. Okay, so this is symphysis pubis. This is metal spine. Okay, the sacrum. So this is posterior, this is anterior. Now look at in relation to the anterior but slightly towards the left side. Okay, so this is left occipital anterior position. Similarly, here you can see occiput more posterior. Okay, in the left side posterior. So this is left occipital posterior position. Okay, and so forth. What about the position in case of transverse lie, other lie? So you can see here the denominator is the shoulder. Okay, acromion of the shoulder is the denominator. Okay, shoulder is the presenting part. Okay, and denominator is the acromion. So you try to look at the acromion. Okay, and we call just dorsum. Okay, here the dorsum is anterior. Here the dorsum is anterior, and here you can see the fetal part, and the dorsum is more posterior. Okay, so this is position in case of transverse lie. Now let's talk about how we diagnose the different lie. So what we discussed now till now is lie presentation. Okay, fetal position, fetal attitude, as well as denominator and position. Okay, so how we find these things? Okay, there are different methods. One is examination, another biophysical methods like ultrasound. Okay, and there are other imaging as well. Okay, but we do not do frequently. Commonly we do clinical examination and biophysical methods. Okay, there are several methods. Okay, so to diagnose. So one is abdominal examination, abdominal palpation. This is very important for you, especially exam point of view. Vaginal examination. So vaginal examination, you just know the theory part. Okay, you do not need to do in examination. And auscultation. Auscultation you should know. Okay, and imaging like ultrasound. Okay, let's discuss ultrasound or MRI in doubtful cases. Okay, so always I think we have discussed this thing in the examination as well. Again, we will do in the tutorial. Okay, so always note the height of the uterus first. Okay, that is called fundal height. Okay, you can see the skin changes, linea nigra. Okay, so this is the midline, this is linea nigra, and these are the stria. Okay, so these are the stria, what we call stria gravidarum. So let's focus on the abdominal palpation. Okay, it is defined by the Leopold. Okay, Leopold and Sporlin in 1894. Commonly we call Leopold maneuver. The mother should be supine. Okay, so to do this examination, mother should be supine, comfortably, okay, in a position with her abdomen bared, okay, open. So the abdomen should be exposed from the jiffy sternum to the mid thigh, okay, or ideally till the mid thigh, but to maintain the privacy, we try to cover the private part, okay, and legs slightly flexed with the empty unit bladder. Okay, you should know the prerequisite. Okay, so patient should be spine, exposure you should know, and legs should be slightly flexed, and you ask the patient to empty the bladder. So it can be difficult, but in case of obese patient, okay, when there is excessive amniotic fluid, polyhydramnios, okay, when the placenta is lying anteriorly, it will be difficult in such cases. Okay, so let's discuss the one by one. What is the first maneuver? Okay, so again we will demonstrate this thing in the our clinical posting. Okay, just know theoretically. Okay, so first maneuver, it permits the identification of the fetal pole. Okay, so here these are the deep palpation. Okay, so deep palpation, so you flat of the hand, okay, should do a form, okay, but gentle. You should be gentle, methodological, and purposeful. Okay, your examination should be gentle, methodological, and purposeful. Okay, and with with taking the mother consent, okay, and slightly flexing the leg. Okay, and you start palpating from the upper pole. Okay, so deep palpation, you try to feel the mass over the which overlies the upper, okay, over the fundus. Okay, so if it's a bridge, okay, the buttock, then it gives a sensation of large nodular mass, okay, broad irregular type of the mass. Okay, whereas head feels like, if had it been a head, then it feels like round globular and palatable mass. Okay, so it depends how we feel. So this is the way we can identify. It helps in identification of what occupies the fundus, okay, in the first maneuver. What about the second maneuver? Yes, first maneuver, when we know it is a buttock in our head, so lie will be longitudinal in that case. Okay, because in first maneuver, if the lie is transverse, then you do not palpate anything. Okay, so that's why first grip, okay, that we call Leopold first grip or first maneuver, we can ascertain it's a lie. Okay, and after determining the fetal lie, now the palm should be placed on either side of the metal abdomen. Okay, so it should be gentle, but pressure should be exerted. So in one, okay, so in one side you can feel the firm resistance feel. Okay, hard resistance feel, structure is feel, firm resistance feel, that is back. Another part you can feel a nerve like structures. Okay, mobile irregular part. So these are the fetal parts. What about the third maneuver? Now in third maneuver, with facing the mother, okay, all these maneuver we have doing just first maneuver, second maneuver, and third maneuver. So we are doing facing the patient. Okay, for third maneuver, just use one hand. Okay, we use the thumb and finger of one hand, and the lower portion you try to grab the lower part. Okay, which lies the lower part, lower pole of the uterus. Okay, so here this is the cephalic. If the presenting part is not, okay, if the presenting part is not engaged, means it hasn't crossed the pelvic brim. Okay, then it is usually mobile and you can feel it. Okay, here the aim is to differentiate between the bridge, buttock, as well as from the head. So how we differentiate? In buttock, the feel is different. Buttock, it is broad, irregular, nodular mass. Okay, in case of head, it is firm, round, globular, palatable. Okay, we can move it. Okay, if it's not engaged. But if the presenting part is deeply engaged, okay, if the head is going down deep in the pelvis, when the biparietal diameter has crossed the pelvic brim, okay, in that case, we have to go for another maneuver. Okay, now fourth maneuver. So look at the position of the hand. Okay, now we have to face the mother feet. Remember, in fourth, we have to face the mother feet. Okay, and the tip of the first three fingers, okay, we try to exert the deep pressure in the direction of the pelvic inlet. Okay, towards the pelvic inlet, we try to exert the direction. When the head has descended into the pelvis, we can then, if head is going down, in that case, you can feel the anterior shoulder. Okay. So look here in fourth maneuver with the two hands, we try to direct our hands towards the pelvis. Okay. And when there is diversion, in here you can see the diversion of the fingers. That means the head has already passed down in the pelvis. That is engagement. Okay. So in this case, we can converge our hand. So this is not engaged. Okay. So what is engagement? In engagement, when the largest transverse diameter of the fetal head. What is the largest transverse diameter of the fetal head? Okay, so don't worry. This again, you will have a separate lecture in maternal pelvis and fetal head. Okay. Excuse me. Okay, excuse me. So basically, engagement is when the largest transverse diameter of the fetal head. Okay, that is biparietal diameter. Okay, so largest transverse diameter of the fetal head, that is biparietal diameter. Okay, so when the BPD, biparietal diameter, it crosses the pelvic beam. Okay, so imagine here. Okay, so now here this is the beam. Okay, imagine this is the beam. Okay, this is the beam. Look at the biparietal diameter, it has crossed. Okay, so here it is engaged. Here you can see the biparietal diameter, this is the beam, it has not engaged. Okay, it is up. So it is not engaged. Similarly, you can see in the picture, look at the biparietal diameter, it has not crossed. Here the biparietal diameter, it has crossed the pelvic beam. Okay, so this is head engagement. Now, what are the extra information we can get from the Leopold maneuver? Okay, to sum up, you can see there, this is the longitudinal lie with the infundal grip. We can feel the broad irregular mass. So this is bridge. But here the presentation is cephalic, because what overlies the lower part, lower segment of the uterus? Yes, it is the fetal head. That's why here the presentation is cephalic. Then again, you try to palpate where is the back. Okay, in second maneuver, you try to locate the back. So if it feels the smooth resistance feel, okay, that is back. If you feel like irregular knob-like structures, okay, so that is fetal limb. And in third, try single hand. Okay, try to grab the lower part. If it's a globular, okay, mobile form, then this is the head. Okay, and in fourth maneuver, if it's engaged, then it is difficult to fully grab the head. Okay, so that's why our hand will be diverged. Okay, and if the head is not engaged, then our hand will be converged. Okay, so this is all about the Leopold maneuver. Okay, so what are the extra information we can get from, let's say when you grab, okay, when you do the third maneuver, when you try to grab, so you can see the relative position. Okay, when you grab this, both are the cephalic presentation. Okay, but what you can see here this is the well flexed, here is a deflex. It is not well flexed here in this figure B. Okay, so when you try to grab, your relative position of your hand will be in a different location. Okay, look, so that's why even Leopold maneuver, okay, it can give us an idea about attitude as well. Okay, so we can have an idea of attitude. Okay, so if there is it may cut off. Okay, Zoom, I think it's time out. Then again rejoin. Okay, so it gives, what about the Leopold maneuver? So it gives idea about lie, okay, presenting part, and attitude. What about the denominator? So can you find, do you know denominator? Can you ascertain the denominator